Very good evening, my beloved colleagues. We are congratulating you to today's our regular session of AKT Basic. Possibly in the meantime, you came to know that our topic is today of ECG in AKT exam mainly. But my colleagues, I like to add that it is not only for the exam purpose, what we are practicing with the ECG in our day-to-day practice. We will try our best to present you the informations and the ECG tracing, which are really important in our general practice or day-to-day practice. So keeping in the mind, don't think that it is only for the exam, though we will show you some exam scenarios related with the ECG. And ECG is a big chapter though. Today in the one class, we will try our best to highlight the very common issues with the principles of ECG, how to read it, and with some examples. So let's go on with me. This is my humble introduction, as you know before. And this is our institute. And definitely this is our moral alert that these are restricted material. You already know in the meantime. So if we start with ECG, just a picture shown to you now. Somebody, Dr. Hayam is busy. Possibly Dr. Fabina, please. Can you interact with me, please? Our class will be really interactive. So active,
Yes,
be active all the time. Thank you, doctor. So what you are seeing here, it will encourage me for that, doctor. You see that there are 12 lead ECG, right? 12 lead ECG. Everybody is saying it. You see that the all 12 leads are not as it is, right? They are different.
Different axis.
Axis different, voltage also different.
Mm-hmm.
Upper, lower deflection, all are different. If I ask you, can you say me one ECG tracing where all the waves are negative? Can you say?
AVR.
AVR. Okay. Any other one? No one. You are absolutely right. All the waves are negative in AVR. This is very normal. So can we see any lead where all the waves are positive? Anyone?
One.
Everybody
Lead
search.
one.
Everybody search, and if you find, anybody can respond.
Lead one.
Lead one, doctor. All are positive. How can you say? What is this?
Oh, okay.
One is anywhere? Almost no. No one.
Yeah.
No one. But I like to highlight, we need to remember all the 12 types of normal ECG. If you cannot remember, by drawing in the paper, try to remember. In the right side, the deflection pattern is explained in electrical axis. This is simple. As the heart axis is the left lower position, down and left. So the electricity going towards the left and down, the deflection will be positive more on those leads. But AVR, you see the R. So R in against the anatomical axis of the heart, against the electrical axis of the heart. So the R is negative. Hope this is clear to you. And another word I like to highlight, the reciprocity. You can see here, I will use the word in coming other topic also. Reciprocity, you see that if in the left-sided word 1, you see lead 1, okay? You find that the lead 1, the positive reflection is bigger than the negative reflection. Whatever it is, RS or whatever. Is it right, doctor?
Yes, doctor.
Yeah. If you come to the, it is right-sided lead. Suppose compare right-sided lead means in the V1. It is V1 is the chest, right-sided lead. Or you can see the AVR, though there is no positive deflection, you see that the negative deflection is the prominent. Understand? And the positive one very small, or actually there is no positive deflection. Comparatively, if you say in another lead, in the right-sided oriented lead, if I give an example of the V1, you see that the R is smaller, S is bigger. If you come to the left-sided lead, 5 or 6, you see R is bigger, S almost not visible. Okay, or you can say the Q is here, it is smaller. So this is just balance. It is called the reciprocity. And remember this word, I will discuss it somewhere else. Reciprocity. Okay. Now the true picture of 12 leads of one patient. Here again the same thing. You see that then the lead 1, lead 2. You just compare the V1 up to, you see. Just see that the from ECG is going from the right to the left. Right to the left. You see R is progressively becoming taller. Up to 4, up to 5, and the 6 a little lateral for that it is becoming down. So if you compare with the V1 and the V5, you see the V5 R is bigger. Similarly, S is smaller. Here in the V1, R is smaller relatively than the S. This is the reciprocity. When electricity is going one side, the opposite lead is receiving and giving the signal of the negativity in the ECG. Okay, so try to remember this thing. And here the standard speed of the ECG is 25 millimeter per second, and we need to know the definitions of that. I hope all of you remember it, and sometime if you don't busy with this study and you might forget. There are some words, interval and the segments. You see this is interval from the beginning of P up to the beginning of QRS. So this is PR interval, but up to the Q. Why it is PR? Because in some lead there is no Q wave. For that we need to count up to the R. Actually, perfectly if you want to say, we have to say that the interval between the beginning of the P wave up to the beginning of the QRS complex. Whatever it is, a Q wave or R wave, not the problem. But traditionally we term it is as PR interval. And then come to the ST segment. ST segment, you see, ST interval. This is interval. You see the yellow color. The word is interval, not the segment. So you segment here, ST segment, you just come up to that only here from the beginning, from the ending of S and the beginning of T. This is segment. But when we say the interval from the beginning of ST segment up to the ending of T wave. So there is a definition difference between the segment and the interval. Though ST interval are not much utilized, we will utilize more terminology as the PR interval, ST segment, sometime the TP interval, TP important for other purpose also. TP, this one interval. This is the straight line from here up to there. Another one is QT interval. You see from where up to where. Okay, doctor. In Arabic, possibly min huna ila huna, like that. From here, you see QRS. From the beginning of the Q and ending of, what I said, QT interval. It is written here. Yeah, there. Sorry, I was gone. In this lead, it is shown here. From the beginning of the Q and you see ending of the T. This is interval. Beginning of the Q, ending of the T. We must remember it. Sometime in AKT exam, only definition may be a question because these are too much tricky. Another word is the PR segment. Doctor, look at PR segment. Ending of the P and beginning of the QRS. So this is PR interval. These are the segment. There is a difference of that. If anybody doesn't know, please quickly raise the hand. Quickly raise the hand, please. Otherwise, we're switching. I hope all of you know, just refreshing your memory, we are trying to give. Now, these are the duration in figure. Okay, 0.12 second means 2.5 smallest square here. 2.5. We have to remember the number of the smallest square by timing. Practically, we have to do it. That this is smallest square, 3 is smallest square, 1 smallest square means 1 millimeter. 1 millimeter. Okay, QT interval in general 0.42 second, and this QT interval dependent upon the rate. So sometimes we have to calculate the corrected QT interval. CQT, corrected QT interval. In many where we are correcting in our data. by influence of other factors. So one important factor of the QT interval is the rate, heart rate. Okay. ECG contains wave interval already we described. The segment important is the PR and TP. TP, the importance of TP is when we say the wave is positive, another wave is negative. So there should be one isoelectric line. TP is important for that. If we can identify the TP segment or TP interval, whatever we say, this line will be the baseline, isoelectric line. TP. TP means T of the one lead, P of another lead. It is the TP. Okay. And this is the real 112 lead ECG. Now, question to all of you. Can anybody say any gross abnormality can you see here? Please raise the hand. Quickly look at, please. Don't be busy with very critical thing. Grossly, if you see any abnormality. Raise the hand, give the answer. Don't be serious more. Just frankly and freely say and tell, please. No one responding. Interesting. You look at the waves. And the lead already 12 leads in different positions, segments, intervals. If any major gross findings, I think will become very serious. Otherwise, this is the normal ECG. This is the normal ECG, rate, rhythm. And the rate, rhythm lead will be told as the rhythm strip. And this is the lead 2, usually lead 2. And sometimes V1 also utilized. Lead 2, you see the long lead 2. Long lead 2. So whenever we see how to start with, I will tell. Before that, you see minimum list of ECG findings and diagnoses that a family physician should be able to recognize. So actually those who are specialists also in the South Asian perspective, all are general physicians, all are family physicians, whatever the specialists. Suppose like me, in my practice, though I'm practicing as a physician or medicine specialist, actually I'm a general physician, family physician, practically, and I must know it and you must know it. This is the list. If one, you can make a snapshot. So it's a very big list, remember, but most of the ECG diagnoses are known to you. We have to recapitulate, just that's all. If you come to the next slide, you see how to read the ECG. First, look at the whole tracing. Just I asked you before that anything attract you in your eyes, gross findings. Then look at the rhythm. So ask in the ECG tracing by self that is it the sinus rhythm or non-sinus? Sinus rhythm means the P wave is conducted or followed by the QRS complex. And the P position, morphology, everything is okay. It means this is the sinus. That means sinoatrial node. If P is generated from the other point of the atrial muscle, then P's morphology will be different. We will try to show you also later on. Then you count the box, use caliper and the ruler for rate calculation. Though nowadays ECG machine is giving the rate automatically. Even then, if we are confused, we have to see. Sometimes if the rhythm is irregular, ECG machine calculation may not be a correct one. So just this data we have to know. PR interval 0.2, 0.20 means, who can say how many millimeter? Doctor, anyone? P20 second means how many? How many millimeter? How many smallest square? Dr. Famina, please.
5 small squares.
5, fantastic. QR is very skinny, very thinny. Maximum 0.10. Dr. Famina, please. How many square? 0.10?
2 squares. 2 small squares.
More than 2, doctor. It will be
Okay.
2.5.
0.12.
2.5. You see, it is a 5 smallest square. So 0.10 will be the 2.5 smallest square.
Okay.
But when we say the broad, Dr. Famina, when we say broad QRS, if it is more than how many square? Who can say? Who can say? Please, please respond, please. When the broad, when we say this is a broad, Dr. Kabir, please.
More than 2.5 squares.
No, there is a gray zone. Some book may be writing in that way. It will be more than 3 smallest squares to be confident, because the broad QRS is an abnormal finding. So traditionally, the more than 3 smallest square. So we cannot say that less than 3 smallest square is normal. There is a gray zone of 0.5 millisecond. That means sometime the physician can understand correlating with the clinical pictures, even just near the 3 millisecond may be significant one. For this reason, in between there is a gray zone. Now, segment isoelectric, all the segments are isoelectric, normal, but if it is elevated, depressed is abnormal. T wave, upright, flat, or inverted. Abnormalities we can see upright, flat, or inverted T wave. That is our observatory points to see. Interpretation now, normal or abnormal in general after looking this. And if the rhythm abnormality is there, is it dangerous or not? You know that the ventricular tachycardia is very dangerous. Ventricular fibrillation is very dangerous. So without going to other issues, we have to see the rhythm I told you and check rhythm is dangerous for life or not. Forget other thing. Manage the rhythm, and if you need, send patient to the CCO or somewhere. This will be the idea. If we don't understand, our patient may die in front of us in our chamber. So now again, look at the ECG, please. Just be careful, 1 minute or less than 1 minute. Look at if any gross abnormality, I told you before, look at that gross abnormality, can you see? If not, come to the rhythm. Is it regular or irregular? And check apparently the rate. And definitely try to calculate the rate with your previous knowledge, how to calculate the rate. So segment, other, everything. If any gross finding, doctor, you can tell. Don't be very minute, very, what I say, the critically looking. Anyone, please, now. Dr. Femina.
Normal ECG.
Normal ECG. What will be the rate, doctor? How to calculate the rate in real practice? Calculating this
Maybe
big,
about
big,
60.
big.
300 by big squares.
300
Number of
by
big squares.
big square. Okay, 1, 2, 3, 4. A little more than 4.
Yeah.
So we can say that 300 divided by 4, 75. So a
Yes.
little more is their rate will be less than 74. General IQ, less than 74, maybe 72. Right, Dr. Femina?
Yes.
Thank you. Thank you, doctor. Please, everybody interact, please. Otherwise, this is a normal. And is there any irregularity? Possibly no. Possibly no. There may be some little irregularity you may find due to the sinus arrhythmia. Inspiration, expiration can change a little in some leads from lead to lead. So it is not your breaking time. That means not sleeping time rather. Just to recapitulate with few seconds what we said now. Okay. No question. So by closing this, I am going to the next ECG for you. Be with me. Yes, Dr. Femina, can you see now? Hello? Hello?
No, sir. Yeah, I can see the
Next
first
screen. This is another presentation. For that, I just divided it. Initial one was the introduction. Now coming to the specific discussion here.
Yeah, I can see.
So what we will be discussing in traditionally, we are dividing our discussion, and even if you have any opportunity to see our YouTube videos, we divided this discussion in 4 major headlines: ischemic heart disease, arrhythmia, chamber enlargement, and the conduction block. That means conduction abnormalities. So most important is here, who can say important, which ECG will be very important? With logic within your mind, who can say which one, which headline is most important? Dr. Femina, which ECG important for you? For you means in your practice related with the patient, I'm asking. Sorry if you
Ischemic.
don't understand my question. Ischemic heart disease is important for your patient perspective. You are thinking. Dr. Hayam, please, everyone share. Dr. Hayam.
For me, arrhythmia is important.
Why? Why you are choosing arrhythmia?
Arrhythmia because most of the cases it will not be stable and need to be referred, need to be more evaluated.
Okay, okay. Anyone else who can say rather? Any opinion in favor of the chamber enlargement or conduction block? Who can say? You never thought before of this. Anyway, perspective is different, that ischemic heart disease also can be complicated by arrhythmia, but arrhythmia per se will be the most dangerous ECG things, and patient may die within minutes also with the arrhythmia. Anyway, conduction block, suppose if it is the complete heart block, may be dangerous, but whatever you have seen complete heart block, patient die within few days or later, occasional patient escaped from the rhythm problem. But the arrhythmia, suppose ventricular tachycardia and the ventricular fibrillation, most dangerous thing, most dangerous ECG finding. Anyway, we can start with the ischemic heart disease now. Our main attention to be to QRS complex and ST segment in the ischemic heart disease. These findings you often see. Suppose we told you that normal duration of QRS is 0.10. Now we are showing 0.12. That I mean that some authority writing 0.10, some authority writing 0.12. Somebody saying that the gap between 0.10 and 12 is a gray zone. So to be confident that the broad QRS means more than 0.12, more than 3 smallest square. This is the summary now. Now look at the appearance of QRS. When you see the small q, capital Q, different orientations of the QRS. So I will not like to highlight here. I am showing just the different presentation of the QRS. You see the last one, the top, in the lowest right, fragmentation of the QRS, fragmentation or fractionation. This is very important QRS observation, very, very important for evaluation of a block, especially the left bundle branch block, somewhere you can find that you see this is M pattern, M pattern. If it is the reverse reciprocal, it will be W pattern. So many patterns are there, many patterns are there. And here R is smaller than the S. And very importantly, we might be confusing here this RSR pattern, RSR pattern. Here two R, one is a smaller, another is the bigger one, So this is one of the appearance of Q, and this is the description of normal variants of QA. Please requesting all of you make a snapshot, doctor. If we start to read, it will take long time. I think if you read it by yourself, it will be enough. The septal Q waves is a normal. You see, there are respiratory Q waves. And the QS complex in V1, small Q waves. That means these are normal. Actually, we must know the abnormal Q waves. Abnormal Q waves. So you see, these are the abnormal Q waves qualities. Pathological Q waves here in the bottom. If it is seen in the lead 1 up to 3, this is abnormal. Very interesting. That means we don't expect Q wave in the V1 up to V3, chest lead, V1 up to V3. But if it is seen in the V1, V3, think that it may be abnormal. And when we consider the pathological Q, we measure the width of the Q as well as the depth of the Q. Depth is very simple, more than 25% of depth of QRS complex. More than 25 of QRS complex. Suppose here, you see the black area, this is the Q, and this is the QRS complex whole. If it is by proportion, that if more than 25%, that means more than 1/5 of QRS complex, then it will be abnormal. And now come to the area above, the territorial distribution. Actually, it is due to the coronary artery distribution anatomically in the ventricular walls. So 2-3 AVF represent the inferior area of the heart, and the right coronary artery is involved there. Similarly, left anterior descending artery represented by the V1 and V2, and distal LAD is the V3, V4, distal LAD. So proximal LAD, distal LAD, that means anteroseptal. If we say the proximal LAD, so whole LAD is covered by 1 up to V4, 1 up to V4. And the anterolateral, V5, V6, and 1 AVL. You can remember that the left and the AVL a little left than the main axis. So this is the lateral. Sometimes 1 AVL is said high lateral, though it is not mentioned here. Posterior, very interesting. We will try to explain the posterior, how to identify. The posterior also supplied by the right coronary artery. That means the right coronary artery is supplying and represented by the 2-3 ABF also. Usually the posterior MI is associated with the inferior MI. So if you can remember anatomy of the coronary artery distribution, it will be easier for you. So with this word, we are now coming to the next slide. Acute myocardial infarction represented by ST elevation in leads where MI occurs. That means according to this area, inferior MI there. So ST elevation in the ECG finding. Then important thing is look for reciprocal change. Reciprocal change. I will show you now where we can see reciprocal change. I told you before the reciprocal. It is just the mirror effect. Mirror effect. I think if the next slide, it will be easier. Suppose in this ECG, where is the ST elevation? Very easily. Can anybody say quickly?
2-3 AVF.
2, where 2-3 AVF. Easily we can say that this is acute ST elevation, inferior myocardial infarction. Acute ST elevation, inferior myocardial infarction. So if it is the inferior wall, what is the mirror wall, opposite wall? Dr. Sabin, who is the opposite wall?
Dr. V5, V6.
No, opposite wall will be the anterior wall, right? Inferior and the heart opposite wall will be the anterior wall. So anterior wall represented by the chest leads. Okay. So look at the V. Look at the V1, V2. What is this? This is depressed, right?
Depression.
This is
ST
depression.
depression.
So here is elevation. There is depression. This depression is termed as reciprocal change. This is the electrical circuitry within the heart muscle. It may be associated ischemia also, but in the language of the ECG, we will say this is a reciprocal change. Similarly, if V1, V2, V3 show ST elevation, where we will see the reciprocal change? Dr. Sabit.
Doctor, if we see in V2, V3.
V1, V2, V3, V4, suppose ST elevation is there. Where we
Right.
will get the reciprocal change? In which lead?
So that is anterior, and V1 to V4 is anterior.
Anterior. So reciprocal change will be seen in the opposite wall. Which is opposite wall of the anterior? Please, everybody can participate, please.
So in posterior wall, so it will be in lead
No,
2.
no, doctor. Inferior wall. It is not
Mhm.
like a 4-wall chamber, anterior, posterior like that. Not a square chamber. Okay.
2-3
Actually,
AVF.
it will be in the inferior wall.
Inferior.
I will highlight more also. So this is inferior MI now. Already you have seen. Now look at here. A little semi-diagrammatic ECG. Where is the MI here? Inferior MI. 2-3 AVF, ST elevation. So you can find the mirror effect, reciprocal change in the anterior lead. If you start from, suppose this is the inferior, so we can say the anterior lead. You see little, though not too much grossly visible, in the anterior lead, V1, V2, V3 up to this is visible. You see the ST depression is there. ST depression. Okay. Now I covered it. The same ECG. I actually deleted some words here. Even looking at the reciprocal change only. Patient clinically have severe chest pain. Severe chest pain, you have done ECG. I'm just actually making a quiz for you. ECG will not be like that. I will turn to another conclusion later on. Be attentive, doctor. So if you see that the anterior has a just ST depression, you may see, okay, it's not MI, it is only ischemia. But clinical feature telling you severity of the disease, chest pain, duration, everything, it might be myocardial infarction. So if it is so in the anterior lead, by closing our eyes, where we can say the MI actually happening, myocardial infarction happened. Please, anyone?
Inferior myocardial.
Exactly, inferior myocardial infarction. Now, this is anterior MI, V1, V3. So we will say that the reciprocal change will be found in the inferior MI. You see, 2, 3 AVF, 2, 3 AVF. This is ST depression. So anterior MI is associated with the reciprocal change in the inferior leads. Inferior leads. Somehow there is posterior MI also. Dr. Kabir said posterior MI. So posterior MI, what will be the lead? Dr. Kabir. Where we will get ST elevation in the posterior MI?
In V1 and V2?
No. Actually, the 12 lead, no lead representing directly posterior. If you consider the anatomical position of the electrode, no one is directly representing the posterior lead. Okay. Now come to that magic. If it is so, again, maybe repeating, reciprocal change in the inferior, reciprocal change in the inferior, but chest pain showing this is myocardial infarction. So where is infarction? Anterior infarction. So I covered it. Actually, there is infarction. Anyway, now come to that. As in the inferior lead, the ST depression, so anterior will be ST elevation. Now look at this one. Why we are telling this is posterior MI? This is lead 1. Dr. Kabir trying to reach the concept. Lead 1 up to lead 3 in the chest, V1 up to V3. What you are looking? Dr. Kabir, we connected with me now. Dr. Ibrahim Kabir. You see, this is R, this is ST depression, this is T. Okay.
Right.
Okay. This is in which lead? V1.
In V1, right?
So V1 actually not representing directly ST elevation. Okay. This is anterior, right? V1
Right.
is anterior lead to the right side. Anterior lead a little to the right side. So what we expect if we place a lead in the posterior chest, we will expect reciprocal of such appearance. Reciprocal of such appearance means these will be down, R will be down, ST depression will be elevation, and ST, the T wave elevation will be the depression.
Yeah.
Depression, right?
Sure.
Everybody now be with me. Everybody now, if we just I am showing the same ECG, it is called the mirror test. Mirror test means just reverse this one. How does it look? Same, right? Same ECG, we just made it upside down.
Mirror effect.
This is the mirror effect. This actually representing the posterior lead ECG, though we are not using any posterior lead. For that, by looking at the V1, by looking these features, R is like the tall R, ST depression, T elevation, indirectly it is representing the posterior MI. This is actually nothing but reciprocal change of the posterior MI. Clear now? It is nothing but reciprocal change of posterior MI. Just flip the ECG, then you will understand. So every ECG we are not flipping. When we flip means just to identify is the ischemia if patient presented with the chest pain. And if you find that this one is high up, usually I told you in the chest lead, R wave will not be too much high, smaller, and R wave will be progressively increasing. Okay. To be more confident, after flipped over the ECG, now look at, are there significant key wave? Dr. Ibrahim, is there any significant key wave when you flipped up?
No, sir.
No? Is not Q now? When you actually made it upside down, now it become like this appearance. Is it Q? After making this upside down, is not Q. This is Q.
This is
one.
Q, right?
This
Yeah.
is Q. And
Yes.
is it ST elevation?
ST elevation, right?
And appearance is typical curved up like a
Right.
cap. And this one, ST depression. Sorry, T inversion. T inversion.
Inversion.
So
Right.
there are three questions. Are there significant Q waves? Is the ST segment elevated with a curved appearance? Are
Yes.
the T waves inverted? If all
Yes.
answers are yes, most likely this is posterior MI.
Right.
It means there is some other reason of to appear like that also. I am telling most likely. This less likely, there's some other differential. Let's go there. These are the three. If this tall R, okay, tall R in V1, in the setting of acute inferior MI, remember, I told you posterior MI actually associated with the inferior MI, more likely. Though there is some anatomical aberration, if you can remember anatomy, crux of the heart from where the coronary artery divides and diverts. There is some congenital difference also there in the coronary distribution somewhere. Anyway, in general, acute inferior, that means the right coronary artery is associated with posterior MI. So reciprocal change, you see, causes of the anterior ST depression, one is posterior infarction, or it may be associated reciprocal change, or it may be concomitant anterior ischemia. These are three common causes of ST depression in the V1. Any combination can happen. We don't know which coronary vessel is blocked. Maybe more than one vessel also blocked. It can happen. I hope this area is very tricky, and some of you might know, or some of you might not know. In your previous life, you would be confused, and I also like you before. But up to my understanding, what I got it, I just shared with you. Actually, this is my personal understanding to identify this. If you have any query, my beloved colleagues, anytime you can open the hand, raise the hand, and we can discuss those. Now look at the acute inferior myocardial infarction with the reciprocal change, or it is posterior MI. This is a question to you. Now solve the question. Look at the ECG. Is it actually reciprocal change or posterior MI? You have to imagine just by flipping the ECG. So by imagination, you flip your ECG. Tell me, this is a reciprocal change. Reciprocal change means this is the V1 I'm telling. You see? Is it reciprocal change?
No, this is inferior MI.
Inferior MI is there. Is it associated with the posterior MI, or this change in the V1, V2
No,
up to
it is
V3?
associated with the posterior. Associated with posterior.
Is it reciprocal change for the inferior MI, or it is posterior MI?
No.
No,
It is
I
a
think
posterior.
it's a reciprocal change for inferior MI.
Reciprocal change or inferior MI. So if you flip up, can you imagine that these R will be the Q and Q will be more than 25%? Possibly no. If you consider V2, forget the V1, now come to the V2. Will it be more than 25%? I think so. Right? Here.
Could be.
Could
Yes.
be. I'm just using the pen here. This one. Can you see the color now? So this one will be more than 25%. If you flipped up, this ST segment will be go up. Can it be curved up ST segment elevation?
Yes, doctor.
Yes. So two you can get. If you flip up, the T will be depressed. This T.
Yes. Yes.
So all the three answers are yes.
Yes. Yes, doctor.
If it is so, what will be the
Right.
answer? Is it posterior MI or reciprocal change?
Posterior MI.
Sure, doctor, everyone?
Because all three changes are there.
You see the three questions. Are there significant Q? Is the ST segment elevated with curved appearance? Are the T-wave inverted? Three basic questions. So all the answers are three here, right? Dr. Sabir.
Right. Yes, doctor.
So is it reciprocal change or posterior MI now?
Posterior MI.
Posterior MI. So what is the
Posterior MI.
diagnosis now? Inferior MI with posterior MI.
With posterior MI.
Yes, inferior MI with posterior MI. I think clear to you, and some of you may be happy today. I believe, like me. When I understood this thing, I became much happy. Understanding the posterior MI. If you understand the posterior MI, all the concept of MI will be clear to you from any wall. Okay. Now again, this ECG, is it normal? Or any posterior MI, inferior MI, anything?
Normal ECG, doctor.
Possibly we have seen it before. Thank you. So always the ECG normal. ECG normal is a question. For that, many after I am showing you the ECG, asking you, is it normal? Is it normal? So is it MI? Is it MI?
Yes, yes, doctor.
Which MI? Which area? Which segment? That means
That is
which territory?
inferior lateral.
And
Inferior
first
lateral.
identify inferior and then come to the lateral if there.
2-3 AVF
2-3
inferior, doctor.
AVF you are thinking. Possibly all of you agreed. If you don't agree, then interact.
Then
and discuss.
V5, V6 lateral.
V5, V6, V5 is lateral. Is there any ST elevation? Where is the TP segment? TP, the P of the next lead and T of the previous lead. This one TP. This is a TP segment. That is, if you see 1 millimeter below here, from there you make a straight line. You make the straight line here. I am just again using the pen. Please try to follow. If you have the mobile phone, may be difficult for you. This is the TP segment. Can you follow, Sabine? Dr.
Yes,
Sabine?
yes, doctor.
If I, sorry, it may not be straight one. If you like the straight one, this
Yeah.
is baseline.
Right.
Isoelectric line. So can you say that this is a stimulation? No.
No, doctor.
Again,
Yeah.
come to the B5. It is the
Right.
P. This is the segment, TP segment.
Right.
It is obliquely placed in the tracing.
Right.
Just
That is
I'm
obliquely
just
placed.
comparing what we learned. That I mean.
Hmm.
So if we consider in this way also, it is not a ST elevation.
Right.
Because we need to consider which one is isoelectric line, not by simply looking at this ECG, it is a ST elevation, because their pen is writing on the paper. There may be some technical reduction problem also.
Hmm.
Okay.
Okay. Right, doctor.
So I'm just cleaning it. So if it is so, this elevation may not be there. Rather, we will search reciprocal change the anterior lead, maybe V1 up to V6. Is there any reciprocal change? V1, you search the B1, B2, B3, B4. Is there any ST depression? Can anybody find?
There is no ST depression, doctor.
Maybe very minor, maybe V3, you see a little depression could
Yeah.
be there in the V3. A little, not much. Okay. So if
Not
such patient,
significant.
sometimes reciprocal change may not be visible. It is also true, technical reason.
Right.
And if 2-3 ABF ST elevation is there, if patient having the already chest pain now, so reciprocal change, yes or no, it is not the matter.
Right, doctor. Yeah.
If clinically we can see that this chest pain is suggestive of myocardial infarction and the ECG finding is 2-3 ABF elevated, practically we have to think this is inferior myocardial infarction. But if patient is not in front of me, I don't know the patient having chest pain or not, 2-3 ABF is elevated. So this reciprocal change will be helpful to say that yes, now the patient having myocardial infarction. So reciprocal change is very important. Okay, anybody else telling the diagnosis? No one. PR segment depression. So you are thinking that this is inferior MI now. Okay. 2-3 ABF. Is there any other ST elevation? Anywhere. Doctor? So we are thinking before, this is inferior myocardial infarction. But ST elevation anywhere else? Suppose look at 2. There seems to be ST elevation also. Okay? Or 2, 3 ABF ST elevation you said. But what is the typical nature of the ST elevation? That means the coved up or concave down. That means the concave. Now we are coming to a very critical position of understanding. Dr. Ibrahim Kabir, please. Why not responding?
Yes, sir.
Is the ST elevations are? Dr. Sabin said there is inferior myocardial infarction. That was, I have given the query mark here.
Right.
Is the ST elevation is coved up like a cap?
No, stimulation is not coved up.
Not coved up. Can anybody identify anywhere ST elevation is coved up? Anybody? No. Actually, no. So we are now confused that this is myocardial infarction or not. Second thing, if we identify 2, 3 ABF, okay, right, ST elevation is there. But is there any other lead showing ST elevation, which we cannot calculate according to the coronary artery territory? This is second question. Third question is, interesting finding is PR segment depression. Suppose a patient presented with the chest pain, it may be myocardial infarction or it may be pericarditis also. Maybe from undergraduate life you are learning this thing, that pericarditis also can cause ST elevation, but the appearance of ST elevation is chair shaped, simply to be chair or concave, not coved up. It is satisfying this thing. Suppose if you can make it ST elevation also very difficult to say. If the suppose P and P, TP, if you see the TP here, if you consider the same lead TP, if you can calculate that this is a little elevated, 1 millimeter, 2 millimeter, we are very curious to say this is a ST elevation. Even then, it is not coved up. Can you see here, doctor?
Yes, sir.
Coved up. So coved up may not be myocardial infarction. So we are suspecting now it may be pericardial
Right.
inflammation. To support the finding, that is, we are confused about the ST elevation here. This is myocardial infarction or pericardial inflammation. So come to another specific finding related with pericarditis. This is PR segment depression. Can you see the PR segment here? There. Okay. Just PR from P to R. If you come here a little, the ST segment is here. TP, and below this is PR. I'm just making a small, doctor. Hope it is visible to everyone. PR. Try to identify PR. Here also little. Possibly you have seen before, is the last time for that you might be confused. So these are the PR segment depression. If you see the ECG in the bigger one, magnifying one, you will be able to understand it. So this is one of the characteristic finding for pericarditis. So practically what we'll do, actually we will do the troponin also here. We are not treating the patient by looking ECG only, but initially we need to suspect that it may be pericardial inflammation, pericarditis. So if we find the ST elevation is not coved up, second point, it does not maintain specific coronary artery territory, and it is associated with the PR segment depression, most likely diagnosis will be pericarditis. Okay, pericarditis. So these are the findings, doctor. Please, you can make the snapshot. If you write, it will take time. Rather, make a snapshot and you can get down also the findings here, where we get the PR depression, in which lead it will be visible more. It is called pericarditis. Now come to ischemic heart disease related enzyme changes. So we are discussing ECG, we have to correlate this. Here, troponin I will persist more than 1 week. AST, we are checking actually CKMB more often, and the troponin I. So for the recurrent MI, we need to check the CKMB. After 3 days, patient have chest pain again. So troponin already raised from beforehand. So troponin I cannot say that the now raised troponin I is due to the second MI. To identify the second attack after 3 days, the marker will be CKMB. Marker will be the CKMB or the CK, whatever we say, after 3 days. You can see from the graph. And accordingly, the ECG changes by hours, the evolution of the ECG. Normal, this one. After hours, ST elevation, coved ST elevation, up to this. In the days, still ST elevation persists, but T wave will be the down after days, after 1 day. Here, T is above. And the weeks, T down, ST elevation going down. And later on, if full reperfusion is there, then ECG will be almost same as normal. But if it is Q wave MI, you know, Q wave will persist. It is called the whole thickness MI. Okay. Initially, we said that the Q wave, the non-Q and Q MI. Nowadays, as television MI, we are utilizing the terminology. So if Q is there, pathological Q, this Q will be persisting for life. There will be no change. So in AKT question, simply one question is, which ECG finding is most specific for myocardial infarction? What will be the answer? Don't you understand the answer after my talk? The ST elevation or Q wave or T wave, which one?
Q wave, doctor.
Q wave.
Yes, yes. Q wave is the hallmark of myocardial infarction. It is in the acute setup or in the chronic one. Chronic one means that in the later life also, if MI happen in any area of the ventricular wall, if Q wave is there associated, this Q will persist for life. So if it is so, in future, if we see any Q wave in the ECG, we cannot say this is acute myocardial infarction. We can say, yes, myocardial infarction happened. If associated with the ST elevation, then we can say it is myocardial infarction. For that, nowadays terminology is ST elevation MI and non-ST elevation MI. Both are MI. So why MI actually? Because there is muscle damage and troponin I is high. This is the answer. Okay. Up to this clinical evaluation is enough for you. You see now how the heart muscles are becoming damaged. 1 hour, 4 hour, and the 8 hour like that. Almost the 8 hour it will take to have infarcted area. Here the ischemic area now becoming infarcted area, bigger one. So if there is a full thickness MI, only on that time ECG will show Q wave, full thickness MI. But this is a partial MI, suppose. That is full thickness is not there. So the Q will not be visible. How to identify? By raising troponin I, cardiac enzymes. So a patient presented with the emergency room, we have to observe minimum 12 hours by making the serial ECG first and sending the troponin I to the laboratory. If I ask you in this one, suppose 1 hour is there and this is MI. Suppose this is MI in this part. In this area is MI. Okay. And the yellow area is the ischemic area. So MI, infarcted area, is smaller here. How to diagnose this case? By the troponin I or ECG? In the 1 hour period, patient told that 1 hour I have chest pain. Who can say? Dr. Famina?
ECG.
ECG will show what? ST elevation?
Yes. ST elevation in.
ST elevation could be there, but will there be Q wave?
No.
No Q wave.
No Q wave. Will there be troponin I high?
No.
In 1 hour, no.
No. So ECG is not actually a matter of living. Troponin I also actually giving no information here. So the early detection of the MI, if ECG can detect, sometimes ECG cannot detect. It is the ECG limitation. So ECG is somehow very important. When troponin I is not high, but ECG will show the change. If I go back again, you see, in the hour, 1 or 2 hour, ECG may be high up. but may not be also. Falsely, it will be showing normal. This is the fact. So we rely upon on that time with the chest pain. Another picture, almost similar thing, expressing a little more. Before minutes, after minutes, you see ECG. Now T is high up. Another lead you can see here, other than the previous slide. In the minutes like that, it is called hyperacute MI. And after hour, like that, and the days, and the finally down, becoming normal also if after reperfusion is there. Now the later part, we are serious about the ST elevation. We are telling that this is myocardial infarction. Now some ST elevation, which actually not MI, come to there. Here, it is called the J point, junctional point. J point elevation. J point means junction between S and ST segment. S and ST segment. Sometimes ECG show that this junction is elevated. But we can say that this is ST elevation also. Can anybody say what is the difference here? Any idea? So it is elevated or not? We can say from TP segment within this ECG and from this T to the P, if the ECG in the same line. Okay. But if it is not in the same line, tracing is not erroneous. We can compare from P up to T here. Then see it is elevated or not. Then see it is elevated or not. So it seems to be little elevated. Here also elevated. Which elevation is significant? This is the question. Okay, so this is the text for you. It is called, sometimes this J point elevation is not the pathological. Normally it can happen. It is called the early repolarization. Early repolarization. I will try to show you again here somewhere. Anyway, look at this. The patient already given some data to you. Is it MI? Can you identify now? Is it MI?
This is early repolarization, doctor.
Why you are telling?
Because there is a J point on the junction
Here?
in the beginning of yeah, J point is there.
Can you see my movement of the eraser here?
Right.
Right. So there is J point elevation. Is it above the baseline?
It's slightly not significant.
Definitely above the baseline. So it is above the baseline. We say that this is ST segment elevation. But you are telling it is normal ECG. So very challenging. Very challenging. If you say this is normal ECG, who will argue with me now that no, this is MI? Can anybody say? Can anybody say? Or argue with Dr. Sabin? Anybody? No one.
Dr. J point is more like rounded in the beginning of ST segment. Next like
No. Just I ask you, everyone, please try to respond. If you be silent, you will learn less, no doubt. There is a T wave, clear?
Yes, doctor.
Clearly visible?
Yeah.
Clearly visible. And the point here, you see, the ST segment and the point, ST junction between ST segment and the T.
Right.
I am not telling that this junction, this is the J point, no doubt. If you come right,
Yes, doctor. Yeah.
this point also almost clearly visible.
Mm-hmm.
I'm giving a line here, doctor, as much as I can.
Yeah.
Here, near about. This point
Yes,
also clearly visible. We can say the T wave started from this point.
Right.
Okay. So I didn't show you, maybe in the right side or another one. Okay, I'm going a little back. Sorry. Another one, ECG. When we said that this is MI. Somewhere. Sorry, I need to go back to for better understanding. Here. There also ST elevation, the typical MI. Suppose it is elevated.
Yes,
it is elevated. So you cannot say here from which point T is started.
Right. Yes, doctor.
Though T wave is visible, the starting point you cannot identify. But here, I'm just jumping. Sorry, doctor, for a little inconvenience. In this
Yes.
ECG, this point is clearly visible. Everywhere point is clearly visible.
Right.
Everywhere is clearly visible. But it will actually make us alert that it might be myocardial infarction. Somewhere have this nightmare. Oh my God, this is ST elevation. Actually, it is not. It is not. So this is ST segment and the T wave is clearly visible separately. It is not ST. It is not myocardial infarction, though it is ST elevation, no doubt. So by term, we can say this is J point elevation. J point elevation.
How we will identify doctor by the angle? يعني
Yes,
it will
by
be
the
more
angle.
angle or
Yes,
it will
yes,
be
by the angle.
less
By the angle.
or less common by angle. أيوة.
By angle. Angle. Very good word. By angle. There is an angle. It is an angle almost. But ST elevation, coved up ST elevation, there will be no angle at all. Confidently, we can say that there is no angle.
And the second point, you said that the T wave starting is very prominent. That's why.
Yes.
Right?
So very prominent means there is angle. Otherwise, how can I say that this T wave is very prominent?
Right.
That means the beginning of the T wave is very clear.
Right. Yeah.
Second one. There is also ST elevation. Okay. You see?
Yes, doctor.
There is also elevation. It is also curved up. Isn't it? It is
Yes,
also
doctor.
curved up.
Okay.
So we are seeing the curved up ST elevation and T inversion here. Where is the Q? Q is not there. Right?
Yes, doctor.
The hallmark
No.
of myocardial infarction is not there. So we are confused. This is MI or not. But with that Q also MI happen. We said that the non-Q MI previously we termed as full thickness damage is not there. So Q will not be visible. But in such patient does not have chest pain. Rather, what patient will have? You can say, patient will have the features of arrhythmia. So if arrhythmia is there, how patient present with pain or palpitation?
Palpitation.
Palpitation. So if any palpitation patient having such ST elevation in the lead 2 rather, it will be termed as Brugada syndrome. There may be a discussion a lot, but type 1, type 2, type 3, but for GP or internist rather, we are not cardiologist, minimum remember this one, the very typical one. The type 1 ECG pattern with the pronounced elevation of the J point, you see, J point is pronounced, they are telling this is J point elevation plus a cove type ST segment. There is a cove. J point elevation is just above here, cove there, and an inverted T wave in the V1 and V2. Inverted T1 and the V1 and V2. So you will be confused with myocardial infarction here. And the clinical feature actually very guiding. One, second, this is a congenital or hereditary disease. If you have this ECG in the previous ECG with any other relative without any ischemic diseases, then we can tell that, okay, it is a Brugada syndrome. This Brugada syndrome is very important in the exam purpose everywhere. So try to just remember the word name, Brugada syndrome. So this is also not MI. Now again asking this is MI or not in this ECG, please. You will tell that, oh, it is also not MI because I am discussing this. What is your opinion? Is it MI? Curved up ST elevation, pathological Q, T inversion. Can anybody identify? Quickly, doctor. We have to finish other things. Is it MI? Which area?
V3, V4,
V3, V4, V5, V3, yes. V4 also, V5 maybe, right?
Maybe,
V5 maybe, V6. But is there any reciprocal change? ST elevation, no doubt.
Yes, but no reciprocal change.
no reciprocal change.
Inferior lead, what do we expect? ST depression. Okay. Without reciprocal change also it may be MI for technical error. Does patient have chest pain now? This is the question. This patient does not have chest pain right now. And there is no reciprocal change. What could it be? It is called left ventricular aneurysm, a complication of the myocardial infarction. Before patient had myocardial infarction, that ST segment is not going down, persisting. Initially, there was reciprocal change. Later on, after resolution, reciprocal change is gone. But ST elevation persisted. It is very, very important ECG finding. Left ventricular aneurysm. This is the picture. Left ventricular aneurysm showing ST elevation like that. Is it MI? Quickly, doctor. You are confused, right? This is ST elevation there, 4. But in the 5, difficult to say. In the 3,
No.
normal. Yes, Dr. Someone, Dr. Femina, possibly telling something. And here 1. AVR, a little R wave is there, a little R.
T version.
Sorry, noise is there. What is our observation? ST elevation in the lead 4. Lead 4, you can see the lead 4, ST elevation. It is coved up or not. If you say it is J point elevation, T is very clearly visible. There is angle. Okay, it may be discussion that whether it is coved up or maybe J point elevation. First, second thing, the inversion in the lead 1 and 2. T wave inversion in lead 1 and 2. So, in the lead 1 and 2, T inversion is there, but ST elevation is not there. In the lead 4, B4, ST elevation is there, but T is not inverted. And if ST elevation we find in one lead, to make it substantial, we have to get another lead also the same changes. It is called the rule of 2 again. Territorial. Suppose when we say inferior MI, minimum 2, 3 ABF. From there, 2 leads should have ST elevation. Only 1 lead ST elevation we cannot say MI. Only 1 Q wave in the lead 2, is it not MI? In general rule. So if it is a lead 4 is showing ST elevation, we can expect that the lead 3 also will show ST elevation. But there is no ST elevation in the lead 3. These are called non-specific ST change. Actually, it is not absolutely normal ECG. Somehow there are some problem inside. It is called non-specific STT change. Underlying maybe ischemia also, but ECG is not correctly showing it. So it is not a particularly specific coronary artery disease. So very often you can find this opinion by the cardiologist in the ECG, non-specific STT change. So these are the causes of ST elevation. We have shown some example, but not all. Useful mnemonic is elevation, to remember it. And these are the common causes we find in our practice, the green color, ST elevation. So Brugada syndrome is not much common, but ventricular tachycardia also showing ST elevation, ventricular tachycardia. Similarly, some few words of ST depression, ischemic heart disease. There are basically 3 types of ST depression. Everybody understand easily, but I like to say as upsloping ST depression. Usually we think that upsloping is normal. So upsloping means that this one, sorry, I think you can see my cursor, I am moving here. Possibly the third one, right? 1, 2, the third complex. Upsloping. Upsloping in general normal, but when it is a delayed upsloping, delayed means if the upsloping 3, 4 small square after J point, this is the J point. After it is the J point, I am marking here. This is J point here, J point. From there, you calculate the 3 or 4 small square. Suppose we can think that 3. So how many smallest square in the 3 means when it touches the baseline, this baseline. So from J point up to here, how many square? 1, 2, 3. This is the point after the 3 millimeter. Even some authors say point after the 4 millimeter. If the point is below baseline, then we can say this is abnormal ST segment depression. But by looking here, can we say this is abnormal ST segment depression? Who can say? From J point up to this junction of the T, this is the ST segment and is the baseline. Almost this is the baseline. So after 3 smallest square, this point is over the baseline. Is it abnormal or normal? Sorry, don't you understand? If
Another more time, doctor, so we can concentrate.
no problem. The abnormal ST, you understood that this one, the horizontal depression, down sloping depression, there is no doubt this is abnormal ST depression representing usually ischemia. But I'm talking about the upsloping ST segment. So if the J point from up to J point up to the junction ST segment to the T wave, this point, if the point here is how many millimeter after in this tracing? How many
After 3.
millimeter? After 3. If it is not after 3, if it is after 5, suppose here, if it is come here like that, the lower one,
Then it will be abnormal.
then it will be abnormal. It will say some pathology is there. But if it is the 3 or 4, some authors say it is 4. This point from the J point. So in the ECG shown here, it is normal or abnormal?
Normal.
Normal.
Normal. This is the difference. This is exceptional message for you. The ST segment depression. Okay. After this long discussion now, come to a scenario. Dr. Hayam, please, can you read for everybody the question?
Yes, 1 minute. A 43-year-old woman with a history of well-controlled hypertension and diabetes presents to your office complaining of intermittent chest pain for the last 3 months. The last episode was 1 week ago. After climbing 4 flights of stairs at work, the pain was relieved with rest. An ECG in your office is shown below. She is currently asymptomatic. Which of the following is the most appropriate next step?
So ECG showing some T inversion, right? T inversion. And somewhere little ST depression could be, but prominent features is T inversion. Okay. Patient presented with intermittent chest pain last 3 months, coming and going. 1 week ago, last episode happened, climbing 4 flights of a stair at work. And the pain relieved by rest. Currently, no pain is here. So, to take any action, next step, we have to think that the ECG showing what here. Then we can decide. Can anybody say what will be your decision? Read all 5 steps. What will you do? Now patient doesn't have symptom, but patient presented the ECG is done.
There is some change in V4 and V6 or?
B4. No, this is the rhythm strip. 1, 2, 5 done. See the rhythm. So B4, B1, B2, B3. So from 3, 4, 5, T inversion is there. Okay.
Okay.
So is it ischemia or not? Previous ischemia? If it is, so what you will do? This is the decision now.
To see, admit the patient.
Obtain the patient's
To be
treatment.
sure, we have to go for the treadmill stress echocardiogram. Interesting. That means when we do a stress ECG or when we do a stress echocardiogram, if diagnosis is not clear, so in the ECG diagnosis is not clear means we cannot say this is MI or not. And we cannot say his exercise tolerance. Currently asymptomatic. So decision will be to do for the stress test. Now come, the stress test will be by ECG or echo. What is the difference of ECG drawing echo? ECG means you have to go for the running. But echo, stress by giving by with the running. But why the echocardiogram is chosen? It is very extraordinary decision making, because it is found that in this age group for the women, especially for women in this group, stress ECG are less informative. They can show false positive. So for the gender basis, our decision will be the echocardiogram, not ECG. But traditionally, we know that stress means ECG. We have to consider this thing. This is the difference between you and other, those who are appearing the AKT exam. We must know it. That we will advise for the echocardiogram, not for ECG, if we want to know by the stress, especially in the female of the 40-50 years of age. Okay. So these are in gist for ischemic heart disease for you. I hope that this discussion, though it took a long time, we took it long time before, because this is very, very important and common ECG we have to face. Arrhythmias are not that much common, abnormal arrhythmia, rather ischemic changes are more common in our chamber. If you don't have further question, you think yourself and go through further ECG before the coming class also, you will read it more. Now come to the arrhythmia issue.
Doctor, I want to ask, if the same questions come to us in the exam, but the gender is male, we will choose the all stress
Yes,
test.
ECG, we can say ECG stress also. Yes, yes, yes.
Oh.
Now the arrhythmia, what our focus will be, where sequence of waves and the width of R wave. This is my understanding, doctor. When I was thinking and learning about the ECG, I am thinking that arrhythmia identification focus point will be the sequence of waves, one after another. P wave followed by QRS, like that. And the duration of the segments, width of the R wave, the narrow R or wide R. QRS, actually R means in general wide QRS or narrow QRS. By looking this, just to start with the talk, we like to say the impulse generation. The impulse made in sinus and made outside sinus. Outside sinus means atria, junction, and the node. Okay, AV junction and AV node. Node is another site of the impulse preparation, and another one is the ventricle. When it happened, you know that if the SN node is failed, then atria will generate the impulse, atrial muscle. Then atrial muscle come to that made in junction, that the whole conducting system, either some the conducting tree, not tree, rather to say the branching of the conduction. You know that the SN node, AV node, bundle, and the distribution. So this is the conducting tissue. But it is also true that if the atrium is diseased, that means atrial muscle, these are the modified muscle, the atrium muscle is diseased, the diseased muscle also can generate the impulse. That we say atrial ECG, that means atrial complex. But it is the bundle is problem, so we can say the bundle block. Okay, can say the bundle block. Come to the next example to make it clear. This is the sinus tachycardia. Why we say? Because the rate is high. It is above 1 is a normal, doctor. To compare the below with the above. This normal ECG, P wave, QRS, T, very, very normal. When you come below here, it is telling greater than 100 BPM. So simply this is tachycardia. As the impulse is coming from the sinus, so this is sinus tachycardia. Sinus tachycardia. Atrial fibrillation. ECG tracing a normal rhythm here. So P wave is normal, but P wave is abnormal. You can see the P wave morphology. It is abnormal. It means this impulse is not coming from the SN node. This impulse is coming from the atrial muscle. So this is atrial ECG, atrium generated electricity. Now, after the atrium generated electricity, what is the behavior of the rhythm? This is irregular rhythm. By looking at the R wave, this is very, very particular for diagnosis of the atrial fibrillation. So we use the word chaotic atrial dysrhythmia. That means there is a dysrhythmia. This is atrial. Atrial means impulse coming from the atrium, because P wave is abnormal. QRS is not abnormal in its morphology. Look at please. Only the morphology abnormal is the P wave. So this is atrial ECG. What type of abnormality? This is dysrhythmia. What is the disturbance of the rhythm? It is chaotic, irregularly regular. So diagnosis is atrial fibrillation. Atrial fibrillation. I like to say you that important finding, sometime P wave is a straight line and somewhere P is very weaker. At that time, how can you say atrial fibrillation? You can say atrial fibrillation by looking at RR interval. If it is irregularly regular, this is atrial fibrillation. But if it is regular, you see below, regular, the down. But P wave is normal, or P wave is so-called sawtooth appearance, whatever. If you can say how, suppose in this ECG also, P wave is abnormal, but RR normal. If it is RR normal, we cannot say this is atrial fibrillation. If RR normal, we will say atrial flutter. Please, any confusion here? Anyone? Raise your hand. No confusion. Okay.
Clear, doc.
Clear. Now come to that. After atrium, the common arrhythmia is supraventricular tachycardia. So supraventricular means it is not ventricular. The abnormality is above the ventricle. Yeah, sorry, it was my slip of tongue before. So what is not visible in the complex? There is a tachycardia. Rate may be more than 150. Is it right? Rate may be more than
150.
150. Usually it is characteristic for the supraventricular tachycardia. But why it is telling supraventricular? QRS is normal. But what abnormality there?
The rate of
P is not visible.
the breathing.
P is not visible. Okay. P is hidden. That means problem above the ventricle. Problem above the ventricle. But if it is a sinus tachycardia, we can understand that P is actually usually will be visible, but tachycardia is much. Sometime the supraventricular tachycardia also P may be visible. Possibility is there. It is not absolute. It is not absolute. So how we are saying? By looking at the rate mainly. Otherwise, it is regular. QRS is not wide here. So it may be supraventricular tachycardia. So another word will be ventricular tachycardia. Yes, I was confused before a little. Now you see the QRS complex is very wide. QRS from here. If you see, start from the Q here, and there is no other wave also. Everything is covered by Qs like that. Okay. And where is R? Forget this wave pattern. Rather look at width of the complex. We can remember when we see the ECG, look at the rhythm strip first. Then we will come to the waves and others. So in the rhythm strip, we find that the QRS complex is wider. And P is not visible at all. P visible at all means maybe visible somewhere, a little fluctuation, but no maintenance of the relation of the P. So AV dissociation. AV dissociation means atrial ventriculum. Their atrial ventricular has no relation of the conduction. It is due to irritable ventricle, maybe inflammation or somehow. So this is regular or irregular? Please, anybody?
Regular, doctor.
Regular.
So regular but wide QRS, and the heart rate is more than 100. Diagnosis is ventricular tachycardia. And the supraventricular tachycardia, I am going back. It is also regular, but QRS complex is normal. It is not wide. Two differences there. And sometime the previous episode might a patient have is premature ventricular complex. That is the ventricular ectopics. If the ventricular ectopics are successive, then we will term as ventricular tachycardia. That means 3 successive ventricular ectopic plus rate is more than 100. We say this is ventricular tachycardia. Okay. So just common arrhythmia, doctor, we try to discuss you and come to the chamber enlargement. Sorry, where will be our focus? Main focus will be the P wave and the QRS. I'm telling the main thing, not all the focus. The main focus P wave, especially the atrial wave, the P wave, and the ventricular complex. Okay, chamber enlargement. I'm not telling about the segment and other. So P wave and the QRS, look at here. Now you are mature enough. Can you say, look at the P wave and QRS? What abnormality are you getting? I cannot enlarge that much. This is G. Can anybody say any observation anywhere? So try to start from the rhythm strip first and come to other area. Is the P
There
wave
is
is abnormal?
double B wave or two B wave?
Double P wave or double peak, you mean?
Yeah.
In which lead you are looking?
I'm looking to
Lead 2.
lead 2, yes.
Seems to be, though not much clear, seems to be. It is the limitation of our projection as a slide. Okay. QRS is okay?
QRS, yes.
QRS is okay. QRS is okay. Okay.
Yes.
QRS is okay. Okay. What is the width of P wave here? Can you calculate from your screen?
Okay.
Difficult maybe.
Yes, it is. I'm trying to make it more close.
Difficult.
Yeah. 2,
So,
3.
Though, so it will be puzzling for you that sometimes I am confused to say the P wave is abnormal or not. Appearance of the P wave as well as the width of the P wave near about 2.5. Elevation 2.5, width also 2.5. This is normal for the P wave. If you come to the Q wave, QRS, so QRS is not wide, but QRS is tall.
Yes, tall, yes.
So in which lead it is tall? Not all lead.
Yeah, it is.
If we say in the left oriented lead.
Okay.
Left oriented is tall. So right oriented will be the down. Other complex will be the down. That is the reciprocal change again. If it is so, we can say that the electrical activity more in the left side of the heart. So electrical activity more in the left side of the heart. So common cause will be left ventricular hypertrophy, muscular hypertrophy. For that, electricity is more there. Electricity is more there. Okay, doctor. So you initially be biased by the P wave, wide, double peak, but not much clear. So look at the QRS also. If we think about the enlargement. So if you see this overlapping ECG is there. Okay, overlapping ECG is there. So left-sided, suppose the lead 1, we can say there is different calculation of the left ventricular hypertrophy. The simpler one I will show you later on, a little later. But look at the ECG now. What happened to the QRS here? Please, anybody?
Opposite or?
Opposite means you try to say.
It's going down.
Sorry. Suppose in the B1, R is taller. So R is taller means the electrical activity is more in the right side. Okay. So if R is taller, what will happen to the S wave in the V5 or V6 as a reciprocal change? Look at this one.
More deeper.
Here S1 is small, but in the V5, V6 or even the V4, S is deeper. This is the reality of the ECG, reciprocity. Reciprocity. Though there is a method of calculation, apparently we can say which ventricle is hypertrophied here? Right or left?
Right.
Right ventricular hypertrophy. So rule is very simple. Rule is very simple. In V1, R is bigger than S. It is right ventricular hypertrophy. Or in the V6, S is bigger than R. Is it justified here?
Yes.
Yes.
Fine.
Yes.
So you can say this is right ventricular hypertrophy. There may be many difficult or complicated calculation by the cardiologist and other. But like general practitioners like us and you, it is enough for say. And we can go for the echo, and echo will tell everything. Okay, doctor. Okay. Now compare LVH and RVH that we have shown before. Two commonly used criteria, Sokolov criteria and the Cornell criteria. Anyway, we follow this one. S V1 or V2 or R in V5 or V6 more than 35 millimeters suggestive of left ventricular hypertrophy. You see here V1, S, V1. You see, so this is down more, and the 5 R is up more, taller actually, taller. R taller in the V5 and V6. Usually it is taller, no doubt, but too much taller. Actually, it will not cross this that much. So if you calculate more than 35, there are some other also SV3, RAVL, there are different calculation. Sokolov criteria actually we follow more than 35, easy. And another one I have shown you, just compare reciprocity. This is right. I think this slide is enough for you, doctor. This slide is enough to make a snapshot to see RVH and the LVH. Now look at what happened to the R wave here. R wave rather not, it is not normal also, it is shorter. Can you see now? R wave may be shorter in some leads, but is it the shorter in all leads almost? Please, anybody
Yes.
should respond. Why you
Yes,
are telling? Why you are telling this is shorter in the chest lead?
Low voltage ECG.
Why low? What is the measurement? Millimeter
The
square.
QRS flex is small
Why small?
because of that.
Small means give the measurement.
Yeah,
Below
with the
10.
yeah.
Below 10 in the
Mm.
precordial lid, chest lid.
Yes.
And
Yes.
below 5 in the limb lid.
Mhm.
But there's an, I think, some confusion might have. I tried to clear it. And sometimes I exchange the views with cardiologist colleague also somewhere. Might be confusion that this measurement from where to where. Okay, doctor? Min huna ila huna. Okay? Look at. This is the lowest point, right? I'm just moving the cursor in the V2. Lowest point. This is the highest point. So it is called the peak to peak measurement. Peak to peak, not from the baseline. Okay, doctor?
Okay.
Yes,
Okay.
doctor.
And the word they have used, you see, peak to peak QRS amplitude. It is not the baseline.
Okay.
It is not the R wave only. It is a whole QRS complex.
Mhm.
So this is the length of the QRS complex. If it is less than 5 or 10, then we can say low voltage ECG. And these are very common, you see, very common diseases can show low voltage ECG.
Mm.
Now come to that difference of this one. Already we have discussed a little before the tall R wave, S wave. Okay, left ventricular hypertrophy. And within the left ventricular hypertrophy, the hidden information is the axis deviation. Now look at in the V1, R is tall, and the AVF in the right side lead down, S is down, more down. So usually ABF, there will be R is high up. R is high up. Naturally, R is high up. If you can remember 12 lead. But here, S is down. Simply by looking at the 1 and ABF, we can say that this is left axis deviation. These are corresponding findings, associated findings. I will not highlight more. You make a snapshot, doctor. It is enough for you to understand. Make the snapshot. Sometimes we see the ECG by putting our thumb, left thumb over the lead one, right thumb over the AVF. Then you see which one going up and down. If left thumb going up, it is left axis deviation. If the right thumb going up, with the right axis deviation. Left axis deviation. And here, is it right or left axis deviation? If you one and ABF, if you compare, doctor, in the right side positive, left side, look at Dr.
Left
Samir.
side down.
Down.
Left
Side down. So my right thumb is going up. ABF
Right
is
up.
going up. So it is the right axis deviation.
Right axis deviation.
But you need to know the lowest information also, additional. Remember it.
Right.
So look at one ABF first. What is changed you have seen here?
One is down, doctor.
One is down in ABF.
AVF is
Down.
not
Down.
significantly
Comparatively down.
down.
So it is a
Down.
different. Both are down.
Both are
How
down.
can it happen? There will be right deviation or left deviation, right, doctor?
Yes, doctor.
Both are down means, is it turned towards the upside down heart? We can say extreme right axis deviation by looking at the ECG. Extreme right axis
Extreme right
deviation.
axis.
But there is some other thing might happen. If you look at the P wave in the ABF, it is okay? Everybody please, everybody please. It is very important ECG in your practice. Is the P wave there?
Yes.
So if P wave is right there, we cannot say that heart apex going up, base going down. Otherwise, everything will be reverse. Okay. Look at the
Right.
AVR. AVR. Where is AVR? This one. Usually, we think that AVR will be down. Okay. But here AVR is up. Is that it? That
Yes.
means axis deviated to the right. So this is extreme right axis, no problem. But look at the B1 and B6. There is an up P wave is there. But you come to the P wave of 1. Can you see the P wave here?
That is downward, doctor.
That is down.
Down.
Down. So initially you might be that it is myocardial infarction. Q wave is here. But it is a defect. How defect is happened? You see that the R wave should be high here, and naturally V5, V6 R wave will be high also. So in the V5, V6 it is normal, R wave is tall. But why in the left side lead though R wave is not tall? This chest lead representing precordial leads, this lead representing the limb lead. Is there anything happened that the right limb lead is becoming left and left becoming right? What do you think? It could happen. But the chest lead is not changed. V1 placed correctly. Who has done it? Who made the ECG? Who used the ECG machine? It can happen. So it can happen means what the reason behind?
It is defect, يعني in just
Wrong
positioning
lead placement. Wrong lead placement. And these wrong lead placement happen in the limb lead. Usually found. The nurse or other or even you or myself, I put the limb right to the left, left to the right. For that, this difference is happen. Showing extreme right axis deviation. Keep in the mind, patient does not have any chest pain, but you are thinking that there is a Q. You see, seems to be Q. Though a Q, R is a little visible here, we might be confused. But look at the AVR also. AVR should never be like that in normal ECG in the upper stroke. Usually, always it will be down. For that, all 12 lead ECG is very important to see. So there is no changing the pattern of here. That V1 chest leads are okay. But can it be happen, doctor, that in the dextrocardia, if it is dextrocardia, it can happen. Axis is going to the right more. But in the dextrocardia, what will happen to the chest lead R wave? V5 and V6 R wave, will it be taller or smaller? Sorry. What do you think? It will not be progressively increasing. Like right axis
be smaller.
deviation extreme, the left are smaller than the V1, V2. 5, 6 will
Yeah.
be smaller than V1, V2. So I'm not showing this
Oh.
ECG because I told you ECG is a very big chapter. We cannot cover everything, but I'm trying to give you the highlight. So this is very important ECG for that I have shown to you. Dr. Hayam, will you need this slip? Doctor?
For me, no, I
Huh?
still am awake.
You're still awake?
Awake.
Yeah.
Awake,
Good.
very full.
Now some issues, very simpler. Conduction abnormalities. PR interval and QRS wide. Our attention will be there. This is first degree heart block. Why? Someone is to say, anyone? Dr. Taiba may be silent today whole day. Why this is first degree heart block? Dr. Ibrahim Kabir not telling. What about the PR interval? Please tell your observation. Can you identify PR? From here up to there.
PR interval is greater.
Greater. It is fixed or increasing?
It is
Fixed.
fixed. Yeah.
This is fixed. P is conducted by QRS or not?
P is followed by
QRS. Each P is followed by QRS
Conducted to.
conducted. If it is not conducted, we will say this is a drop bit. So fixed PR prolonged, but no drop bit. This is the criteria for first degree heart block.
Oh,
Okay.
okay.
Look at again. If you start from here, PR, here, okay? PR, PR. Suppose PR, PR. It is increasing progressively.
Yeah.
Progressive, how much
Increasing.
progressive? Somewhere infinity. And then
Drops.
P wave is not conducted by?
QRS.
Okay. Suppose here, this P wave, this is P wave. P wave over the T. You see?
Right.
P wave over the T. So this is Q wave. Okay, no problem. But here it is not conducted. So if we see in the second degree AB block, how we are differentiating by Mobis type 1 and Mobis type 2. So in the Mobis type 1 is progressively increasing PR with drop bit.
Drop bits.
If you want, you can write down in this manner. I am not telling as it is in the slide. Progressively increasing PR with drop bit. It is one Quebec phenomena. So give me a few seconds, doctor, to clean it. Otherwise, it will remain as such. Now come to the second slide. That is the next slide. What is observation here? There is drop bit. Am I right? Everybody
Yes.
clear? No doubt.
Yes.
But what happened to the PR? It is progressive, increasing?
No, it's not progressively increasing.
Not progressively increasing. And it may be prolonged or may not be prolonged. It may be normal, but there is a drop bit. So what is the sole criteria in the ECG? Only drop bit without any change in the PR. This is second degree AB block, means Mobis type 2. These very, very key words. Try to remember, or you write in the paper and memorize further, so that ECG will be easier for you. Now this one.
Total separation.
What happened to the P wave QRS. Identify the P. Do you think that P wave is conducted by QRS? Seems to be right somewhere here.
Yeah,
Maybe
here it is.
seeming that this P is conducted by QRS. ECG showing. Now P is not conducted. This P is maybe conducted. But how can we say that they conducted? P should have a peer interval. Is there any peer interval?
No, it
Okay.
is
No.
destroyed.
No. Okay.
No. Mm.
And this P again, where this P and another P again in the angle. Here also another P. Sorry, here also another P down. So P is hidden within the QRS.
Right.
Okay.
Where I'm focusing wrongly or rightly? Here, sorry, doctor. Not the blue color, red color. Blue color is the QRS. Blue color is the QRS, the gap, RR duration. Red one, you see the P.
P and QRS. Yeah.
Another P is here. Another P is there. Another P is here. But if you make a relationship, P to the QRS, it is not a fixed relationship.
Right. Random.
Random. Woodward is random. So random means actually there is no relationship. Okay, doctor, we cannot make a random relationship with 100 people. We have a relationship with only one single people. I think you understood what I mean.
Right.
So this more relationship means no relationship. This no relationship is the hallmark of complete heart block. But amongst them, each other have good relationship. RR and the PP. So in the real sense, in the ECG, this discovering the relationship may be sometimes difficult. It may show you that it may be Mobis type 2. Sorry, 1 Quebec. Progressively PR interval is increasing. There is some drop bit. But 1 Quebec will not have heart rate as low as complete heart block. So here heart rate can help us. What will be the common heart rate in complete heart block? Around 40. Remember it. Then it will guide you that could it be 1 Quebec phenomena or complete heart block. So all the blocks in same picture. Make a snapshot, doctor, and try to match with your mobile phone picture with ECG. Any block ECG you find in your practice. So this is the first degree AV block. Second degree Mobis type 1. Okay, 1 Quebec. Another name is N Quebec. And here Mobis type 2. There is a drop bit. And this is complete heart block. You see. PP. You see. PR prolong. Smaller. This is a drop bit. Okay. 1 Quebec will have drop bit, but progressively increasing PR. It could be. If you see that there is no progressively increasing, but suddenly there is a drop bit. So it may be these one not related to each other. So if you confuse also, now calculate the heart rate here. RR around 40 usually it is found. A question to you now. Try to give the answer, please. I hope you can. Everybody can give the answer. BOPA insurance means asymptomatic patient went for the general checkup. Those who are working abroad, you know, especially in the private sector in the Middle East country, you are working under insurance. I think I am right. Right, doctor? Those who are working in the private sector. So BOPA is very renowned insurance company. So in the health checkup, to be registered in the insurance, we have to go for some tests like ECG. So this is the ECG. Look at and give your answer.
First degree heart block.
Reason is?
Second degree.
Second degree. Which
PR.
second degree, doctor? Mobis type 1, Mobis type 2? I am not ignoring any answer, doctor. Don't think that the first degree is wrong.
I think, I think Mobis type 2.
Mobis type 2. Doctor, anyone please, Dr. Kabir, what is your opinion? Is Mobis type 2? I'm telling you, this is the P wave. So not a straight line, wavy, maybe shivering patient. This is P wave, this is P wave 2. Is the same. Duration is same.
I think first degree heart block.
But is it prolonged or not? Prolonged. Same prolonged.
Prolonged, but
Dr.
not
Khayyam,
progressive.
is there any drop bit you identified?
No.
No drop, no drop. No, yes, you're not dropping.
No drop means no two.
Yes, no second, yeah, no second, yeah.
No drop bit means not second degree.
Yes, yes.
So it will be the first degree.
First degree.
First degree. First degree. Thank you. Anyway, this is the description of that. Causes of the first degree heart block is very academic interest question. Okay, even it may be normal variant also, first degree heart block. Rheumatic fever, other. In the beta blocker, it can produce the first degree heart block. Athlete. Now come here. Block. 1. Which lead, doctor? Left or right? Lead 1. Left lead or right lead? Left heart lead or right heart lead? Lead 1. We must know it, doctor. Otherwise, you cannot correlate. This one is the left heart lead. For that, R is taller here, naturally. Okay? Even the 3 also left oriented a little. But if you say specific right and left, to differentiate, we have to see the precordial lead. Easy to understand. V1 up to V6. So V1 is the left or right? Who can say, Dr. Mahfouz?
Right.
This is right. So what we are looking here in the right, that one, QRS complex pattern, RS, R pattern. Why this is R? Why this is S? Dr. Ibrahim, why this is S? Because this is below the baseline.
Right.
Below the baseline. The definition of S wave is the deflection below the baseline after R. It is S. The deflection below the baseline before R, it is the Q wave. Otherwise, you will be confused which is Q, which is, because as this is R prime, that means secondary R. So S is before, you can say that this is Q. No. By definition, initial R followed by deep, this is S. So this is the pattern is called RSR pattern and seems like to be an M. It is called M pattern. Dr. Ibrahim, what is the duration of QRS? Is it more than 3 or not? Someone have the network problem. I'm sorry for you, my colleague. It's coming and going. Is it wide or not? QRS complex seems to be wide. Seems to be wide. So M pattern in the V1 and reverse pattern. This is the reciprocal change. What will be the reciprocal change of M? Doctor? Reciprocal change of the M. W.
Right.
So is it visible in the V5 or V6? No. But it is visible in the lead 1.
Right.
Because lead 1 is the left-sided lead. So this is the reciprocal change. Wide QRS means block. So if the wide QRS happened in the V1 in the R is upright, then we can say this is right bundle branch block. Right bundle branch block. If the reverse happen, suppose here is the M pattern, but V1 will have the W pattern, then it will be left bundle branch block. Now come there. Is the right bundle branch block. Left bundle branch block. Okay. Now the wide QRS complex in the left oriented lead. You see, doctor? The 1, 5, 6, everywhere is M pattern. So we can expect that somewhere will be W pattern. W pattern may not be visible also. The right-sided lead will be W pattern. Can you identify any right-sided lead W pattern here? Which one? 100% right-sided lead, doctor? 100% means the all deflection are down. We discussed before. AVR. Dr. Ibrahim, can you say AVR? Though that this is not marked by the picture here. What is AVR? Is there any W pattern?
It is in the W
So-
pattern.
So this is the reciprocal change.
Right.
Okay. So in the
Yeah.
left-sided lead, the QRS is fractionated by M pattern, and the right-sided lead showing fractionation with W
Right.
pattern.
Right.
So what is the block name will be here? On which bundle?
Left bundle.
Left bundle branch block. But the basic thing is wide QRS should be there. Wide QRS is the basic thing of bundle branch block.
Bundle branch.
Sometimes this fractionation may not be visible well. But this fractionation is very characteristic. Very characteristic. This is the picture, doctor. I tried to show you. Not that much bright picture. You can see mid QRS notching. This fractionation means notching. QRS notching here down. Okay. QRS notching here down. So if in the V1, if it is the V1 wide V1, where is the V1? If it's not in the V1 or in the AVR, look at Dr. AVR, it is wide and above. So we have to compare the left lead with the right lead. Then we can identify. Okay. So wide QRS, which is negative in the lead 1. In the lead 1, see wide QRS, they are showing negative. Sorry, this is not visible much. The picture is not visible. You look at the description. There could be like that. The wide QRS visible with notching or without notching. Negative in the lead 1. QRS negative in the lead 1, suppose. Negative in the lead 1 means right sided the negative. So it will be the left bundle branch block. Okay. So fractionation in the lateral precordial leads is important. This one, the picture, and help to recognize true LBBB. Remember this. Fractionation is very important for LBBB. Now quiz for you. Identify the block here. Which block?
Yeah.
Which block?
LBBB.
What is the reason?
Lead 1 M
One-
pattern.
Yes. It's the left-sided M pattern and right-sided which pattern?
W pattern.
Which one right-sided?
AVR.
AVR clearly visible here. Now the next question. Is there any ST elevation? Doctor? We are confused, right?
1V2.
ST elevation? Maybe ST elevation.
Yeah.
But as a rule, if LBBB is there, we cannot comment on ST elevation. Very hard to comment. Okay.
Hmm.
And it is found that if LBBB is there with the chest pain, until proved otherwise, it is myocardial infarction. Without chest pain, maybe
Yeah.
only LBBB. Interestingly, we have some patient, my patient also, they don't have any symptom. Usually, you know that RBBB is common variant, right, Dr. Ibrahim? Everyone you know.
Yes.
RBBB is a common variant. Okay. But few patients I observed, and I shared with cardiologist opinion also. I have gone through very little literature about that. LBBB like ECG may be asymptomatic, but LBB is very dangerous. LBBB means immediate correction needed, but without symptom, it is possible. So this is LBBB. Here, what is the block or anything? Identify. Please identify. Try to identify.
Dr. RSR pattern in V2 and V3.
Yes.
V2, V3, RSR pattern. Okay, this is the M.
M pattern. Yeah.
So it is in the right-sided lead, right?
Right sided.
Right-sided lead. If you can see the AVR also showing to be M a little, but more visible in the V1, V2.
Right.
What do we expect? If it is the RBBB, we expect that in the left-sided lead we'll have W
Yes.
pattern.
Yeah.
But what we expect, always expected thing we may not get. But one finding is important here. But look at the wide. Very important is the wide. Is there more than 3?
Yeah,
Seems
hard
to be.
to
Seems to
say.
be. Seems
Yeah,
to be.
I think
it
more
looks
than
wide.
3.
More than 3. If it is a more than 3, but you can see in the S, it is a slur. It is called the slurred S. Delayed S. You can see in the V6. Okay. So our summary will be, if it is a more than 3, then it will be right bundle branch block. If it is not more than 3, it will be partial. Okay. Incomplete RBBB. This is RBBB more than 3. So if we find QRS wide in any SCG, look at the one, B1, B6, but we have seen AVR also. I think AVR also is a good one if findings are there. AVR. Then identify it could be typical RBBB or typical LBBB. Okay. But you are confused. Typically RBBB or not RBBB, your diagnosis will be intraventricular conduction defect or intraventricular conduction delay. Sometimes ECG report is like that when cardiologist is confused. Okay, doctor? This patient have the chest pain or some other disease underlying heart. It may be RBBB or LBBB, but no symptom, only ECG like that. It may be intraventricular conduction defect. Okay. Fine. So this algorithm assume that the rhythm is supraventricular, not ventricular tachycardia situation, and that QRS widening is not due to WPW syndrome. These are the fallacy with which we deal, then we will be confused. So this is the message. So ECG will not be having the ventricular supraventricular tachycardia. Okay. Rhythm, sorry, is the rhythm will be supraventricular rhythm, but not ventricular tachycardia. Remember it. That means the rhythm problem in the ventricular problem, supraventricular problem, but not ventricular. And that QRS is not due to WPW syndrome. That means ECG will be supra 1, supra, not VT or not WP. In that case, we can conclude in this way with the white QRS. So lead to strip. Now tell what is wrong here. When you see the white QRS, seem first bundle branch block. If not bundle branch block, it will be IVCD. But can we satisfy the finding with the bundle branch block, left or right?
Bundle branch block is not satisfied, I think.
Which bundle branch block? Left or right? 5, 6. Is it wide? But wide is there. You see 1, 2. QRS is wide, much wide, more than
Right.
3. So if it is the left oriented, it will be the left bundle.
Right.
Right oriented, it will be the right bundle. What is that?
Ventricular conduction delay.
If you cannot say that is a fractionation is there, we can say conduction delay. So is it LBBB or IVCD? Decide now. Is there any fractionation in the white QRS?
No,
Fractionation means the notching.
no notching.
No notching. If it is not notching, it is IVCD.
IVCD.
Look at here. So there is a W pattern find in the lead 2. So see above others 2, 5, 6, 1. What could it be?
Left bundle branch block.
Left bundle branch block. Why you are telling 5, 6 is the white QRS? White QRS?
In lead 2, there is W pattern.
Okay, okay. So there is some additional information to show you. Okay, we are thinking that there is some block. If block is there, it may be the bundle branch block. There may be the fascicular block. Okay. Suppose AV block means PR interval, right? Look at the PR. Is it prolonged or not? Doctor, is it prolonged? So PR prolonged means it representing which part of the conducting system? Bundle of his.
Bundle of his.
That means the main bundle. So
Yeah.
one component from main bundle. Can anything that component from the right bundle? If right bundle means there will be usually W pattern in the right lead. Look at the AVR, doctor.
There is no W pattern in AVR.
Maybe W. The typical pattern will be the M. Which side having the whiteness, there will be M. W will be in the opposite side as a reciprocal change. So can you identify in the right lead? Because I am just justifying this is trifascicular, for that I am telling in this manner. Common bundle have one block feature. First degree heart block. Right bundle, is there a right bundle block? Look at the AVR. You see. AVR, is it normal?
No.
Doctor, is it normal?
No.
Is there seems to be fractionation or white? Yes.
Yes.
So the right-sided block is there. We got now right-sided block. If we find the left bundle component also there, then there will be 3 block.
Right.
There will be 3 block. So identify in the left side, is there any block in the left bundle? You see, 5, 6, this is wide or not? QRS? Seems
It's
to be
wide.
wide. Seems to be
Yeah.
wide. But is it fulfilling left bundle or not? Not clear.
Not clear.
But can identify any axis deviation here, the right or left? Left axis deviation, right axis deviation. If you look at the V1 and V6, it is easy. V1 tall R, right axis deviation. V5 more tall is less, is left axis deviation. What you are getting here, right or left? Not easy. Not easy.
Not easy.
Not easy. As V1 is high here, more likely it is right axis deviation. Sorry.
Okay.
Yes, better to say right axis deviation. Seems to be. Because R may be like that. V1 should not be like that. V1 should be smaller. As V1 is high, seems to be right axis deviation. So wherever the right axis deviation, we can say there is right anterior fascicular block. Fascicle means part of the left bundle, anterior fascicle, posterior fascicle. So the 3 components we got here, one from the common bundle, another from the right bundle, and third from the left bundle. So now fulfilling the definition of the trifascicular block. Actually, fascicle means not anterior fascicle, posterior fascicle. There are 3 bundle block. For the terminology, the trifascicular block. Is it clear, Dr. Ibrahim? If it is clear to you, everybody possibly having the clear. So in the rhythm strip, PR interval high, common bundle block. Wide QRS in the AVR, right bundle branch block, and the wide QRS in the B1.
Right axis deviation.
So you see the is a wide, doctor, B1.
Yeah.
So for that, this is it is not tall also, as well as it is wide rather.
Right.
Wide is more important. Wide is more important. So trifascicular block. Maybe only 2-3 minutes, doctor. We can finish. Don't worry. We already exceeded our desired time. But ECG is like that. We need to read ECG in this manner. Look at this. AVR. So this is up. Is it?
Yeah.
And AVR, why this is electricity is positive? That means electricity coming from the right side more. Is it true?
Right.
Right side more. And here look at down. Look at down. This is called a spike happening before ventricular complex or atrial complex. Everybody? This is QRS complex. So before QRS complex means some stimulus going to the ventricle.
Right.
So it is telling that stimulus going to the ventricle. Now which ventricle? Left ventricle or right ventricle? If R wave is high, that means right side activity is more. So some stimulus is happening in the right ventricle. This is the pacemaker. So pacemaker placed in which ventricle usually? Usually placed in which ventricle? Right or left? Don't you know?
Pacemaker, please.
Right. Is it
Right
easy
ventricle.
to place the pacemaker in the right ventricle? So, is a ventricular pacemaker. Clear? So, pacemaker ECG as a GP, you must see, because patient coming to the asymptomatic stage, they are showing ECG, you become, what I said, down. You cannot say. For that, I am showing this ECG. So, this is a ventricular pacemaker. Usually, pacemakers are by chamber, dual chamber. Dual chamber. Look at this one. So, this is single pacing. Single pacing means ventricular pacing. Is there dual pacing?
Yeah, this is dual
Yes,
pacing.
dual pacing. One pacing before ventricle, another pacing before P wave.
After, yeah.
Before P wave. So there is atrial pacing and the ventricular
Ventricular
pacing.
pacing.
So this is a dual pacing. Today you are talking less because ECG may be harder for you. As much as possible from my side, we tried our best. This is the normal findings in the healthy individual. Make a snapshot, doctor. I will not read. Normal findings in healthy individual. These are the ECG finding. Patient does not have any cardiac disease. And with this few words, we are going to tell you that YouTube links are there. And this is our YouTube video, YouTube link, doctor. I don't know, have you seen the YouTube? For last time, maybe today at the 11th hour, doctor, I am giving you the YouTube link. We will give the group also. Rather, I'm giving in the group, in the WhatsApp group for you. Just give me a few seconds so that I might not forget. Already all are you the member of the course WhatsApp. So link given in the group, you can click there. Then you will find this ECG. In the 4 headlines, more detailed discussion as much as possible by ourselves. You can go through this ECG, doctor, from there. Thank you very much.